Hello, my name is Peter Carter. I'm a consultant psychiatrist in Nelft, and I'm also a member of the clinical reference group for London. And this is a training video for GPs which focuses on early psychosis. And as the strapline says, it's to help people get help quickly for psychosis. So to consider some of the learning objectives for this video, and they are to know why psychosis matters, to understand what's meant by early intervention, to help you better recognise the symptoms of psychosis, and to understand the referral pathways for psychosis. Throughout the video you'll see the symbol of a pause button, and the idea of this is that you can pause the video to either write reflective notes for yourself or to discuss in a group if that's who you're watching it with. So to understand why psychosis matters, well, to do that first we have to understand what psychosis means. And what it does is describe a constellation of symptoms which can occur in isolation but typically occur together. If you're to try to match those to ICD, it comes out with quite a broad range of diagnoses. But if we're to draw out some themes from that, typically psychosis presents with delusions, hallucinations, and disorganisation of thoughts and/or behaviour. There may well be secondary features of depression, anxiety, social withdrawal, and a loss of motivation. So how common is psychosis? Well, the lifetime risk of developing psychosis is in the region of 3 or 4 per 100. It's 3 times more common if you happen to live in the inner city. It's higher with social disadvantage. And migrant groups and their children have an increased risk, which is increased by between 2 and 8 times over baseline. Cannabis use is definitely a factor for people in developing psychosis, and particularly skunk. So if people do talk about smoking cannabis, it should prompt you to ask specifically if they're smoking skunk. Psychosis is most commonly an illness that develops in younger people, and 80% of all people developing with new psychosis are aged between 16 and 30. And approximately 5% of people developing psychosis for the first time are 15 or younger. And across England, about 7,500 young people are developing psychosis each year. So it's a common problem. If we're to look at that in economic terms, the total cost of psychosis is approaching 9 billion, of which about a half is in terms of cost due to loss of employment. And if you compare that with diabetes, the total cost is approaching 10 billion, but a crucial difference is that only 2/3 of people with psychosis are actually currently receiving treatment. And the numbers with diabetes in treatment is much, much higher. For people with long-term severe mental health problems, the impact on their physical health is dramatic. So they are twice as likely to die from heart and lung disease compared to the general population. Estimates of suicide are in the region of 10 or 15%, and they commonly occur in the first 5 years. People are at much higher risk of developing diabetes, and that's not just down to effects of medication. People are twice as likely to be smokers, and with all the physical health problems associated with that. People are much less likely to be in employment, and typically people can die from physical health problems between 15 and 20 years prematurely. So why does early intervention matter? Well, we know that first episodes of psychosis typically occur in adolescence or early adulthood. And if you think of your own lives, that's quite a crucial point in developing your identity, independence, sexuality, relationships and career. So failure to intervene early has significant short-term impacts, but it can also have a long-term impact. And we know that the average delay between the onset of problems and people accessing appropriate treatment is in the region of 12 months. So that's a long time in which people's lives are being impacted. We know that people's prognosis is inversely related to the duration of people's untreated psychosis. So how do we know that this approach works? So we know that people in touch with an EIP team have a dramatically reduced risk of suicide. We know that the chances of someone being sectioned when they're in touch with an EIP team are approximately halved. And we know that for people who've already been in hospital, the risk of them being readmitted is dramatically reduced. We know that 3 times more people are in employment when they're in touch with an EIP team compared to standard care. And a much softer but more important measure is that patients and carers say that they prefer this approach. So how is it done? Well, as I said before, the aim is to reduce the delay between the onset of problems and accessing treatment. So we pride ourselves on our accessibility. To help with that, we have smaller caseloads, and that allows us to be more responsive and more accessible. One of our aims is to prevent hospital admission where that's reasonable and where that's possible. And we know that that's going to reduce the stress and trauma associated with hospital admission. And we're also very vigilant and are keen to intervene early when there are secondary mental health problems such as depression, anxiety or drug use. And we believe that this approach overall is something that's going to improve prognosis and outcome. We ensure that evidence-based psychological therapies are offered at the outset of people's difficulties, and these are offered as integral to their care. As an EIP team, we offer support for up to 3 years, although there's some variation across London. Some offer for slightly less. Partly because of the age of the people we're seeing, there is much greater family involvement. And that's important because it offers an opportunity to support families, preserve those relationships, because we know how vital they are to people's prognosis and well-being. And we're also very keen to support people into education and work at an early stage of their difficulties. And these principles are brought together through the NICE quality standards for psychosis. And these are, firstly, a referral to an EIP team. Secondly, to offer cognitive behavioural therapy for psychosis. To offer family interventions. And to offer treatment with clozapine at an early stage. We're keen to have people involved with supported employment schemes. We focus on assessing people's physical health and addressing any emerging concerns before they become longer-term problems. And related to that, we have a focus on lifestyle, diet, exercise, and obviously smoking. We're very keen to offer education and support to carers throughout people's involvement with EIP. So to illustrate these points by way of a case history, a mother of a 23-year-old son who you've not met attends your surgery, and she comes to express her concerns about her son, who is irritable, staying up late, getting up late, and shows little or no interest in work or study, and previously he'd been at university. His mother's very concerned, and she believes his behaviour has definitely changed, and there's no obvious reason for this. At this point, if you want to pause the video and either write some notes for yourself or discuss it in a group, and just to consider what you think the next steps are in managing this difficulty. So I think the first step would be to invite our man in, and to do that with or without his mother. Assuming that's unsuccessful, the next step should be a home visit, and to do that with his mother, so that you can see how he lives, so that he feels comfortable and reassured. But I think it's crucial to remember that you can still refer if you have concerns about his health and you've not been able to see the patient properly or to discuss his difficulties in detail. A learning point would be the importance of an early referral and also keeping psychosis in mind and referring immediately on suspicion of psychosis. So in London, there are 9 mental health trusts, and together they cover the 32 London boroughs. And there is an early intervention in psychosis team for each of those London boroughs. Together they support over 4,000 service users every year, and there are a further 1,500 service users who are being treated for a first episode of psychosis outside of an EIP team. So why is this relevant to GPs? Well, the early features of psychosis may be harder to recognise in adolescence and also when substance use is a problem. We know that 75% of people presenting with a first episode of psychosis have made contact with their GP in matters related to their mental health. So this represents a real opportunity for recognition and referral. We also know that these same people have a lot of concerns over acquiring a diagnosis or a psychiatric label, and also have concerns about what the treatment would involve in itself. And that may make it difficult for them to talk openly about their problems, and that's obviously an impediment to recognition and referral. So NHS England have introduced an access and waiting time standard, and this was brought in by NHS England to reduce the delays in people with first episode psychosis accessing treatment. And it came from a Department of Health publication called Better Access to Mental Health Care by 2020. And what this says is that from April 2016, more than 50% of people experiencing a first episode of psychosis should begin a NICE approved package of care within 2 weeks of referral. And this standard applies to people of all ages between 14 and 65. So to illustrate how this works in practice, there's a short video which describes what this means for general practitioners and for mental health services.
Hi, I'm Simon. I manage an early intervention in psychosis service at a mental health trust. A new national standard is being introduced for mental health service users with psychosis, and your EIP team needs your help to achieve it. From the 1st of April 2016, more than 50% of people experiencing a first episode of psychosis must be accepted onto the caseload of an EIP service and begin a NICE-approved package of care within 2 weeks of referral. Why is this new standard being introduced? Because early intervention in psychosis leads to better outcomes. This new standard is a positive step towards reaching equality for mental health services. Mental health trusts are responsible for meeting this standard, and EIP teams will need help from other mental health services to make this possible. So, how does the standard work? The 2-week period is measured by clock starts and clock stops. The clock starts as soon as a first episode of psychosis is suspected. That person should then be offered an assessment as soon as possible. If they are experiencing a first episode of psychosis, the clock stops once they're accepted onto an EIP service caseload that provides the full range of NICE recommended care, and they are allocated a care coordinator. So, if you suspect someone has a first episode of psychosis, they need to be referred to your EIP service or central triage point immediately, according to your trust procedures. The referral should be recorded as a suspected first episode of psychosis and made straight away. Any delays could affect the 2-week standard. The clock starts no matter where the assessment referral has come from and where it lands within the trust. As soon as psychosis is suspected, the clock starts ticking. That's why it's important for all trust teams to work together to identify suspected first episodes of psychosis and refer people for assessment immediately. But how do you know what psychosis looks like and who should be referred? People with psychosis may be experiencing hallucinations or delusions. These could include paranoid thoughts, odd behaviour, or seeing or hearing things that aren't there. They may have trouble focusing or may have lost interest in everything. So, If you suspect someone is experiencing psychosis, refer them immediately for assessment. Remember, we all play our part in achieving this new standard to bring better care and outcomes for our patients.
So if you want to pause the video at this point, just to write your own notes or to discuss in a group, and just consider what you think the main learning points from this clip are. I think the main learning points are that people need an immediate referral, that this standard applies to everyone aged between 14 and 65, and that you are guaranteed a quick response to your referral, and that the people that you are referring will be accessing a NICE approved package of care. So what are some of the symptoms of psychosis? Well, this slide demonstrates that there is a progression of symptoms. So on the right hand side, you typically think of people with delusions, thought disorders and hallucinations. But before that, there's a period where people might have milder or briefer periods of showing psychotic symptoms. And we'll discuss that in more detail later. But early on, people are experiencing quite non-specific problems, which include anxiety, depression, anger, irritability, mood swings. And while these are very non-specific, they might signify to you that someone's A, in difficulty, and B, that people are possibly showing the very earliest symptoms of psychosis. So what are the most common symptoms? Well, delusions are probably the most common. And just to remind you what they are, these are fixed, false beliefs which are not amenable to reason, and people hold without any evidence and don't fit with their cultural or religious background. So some of the types are people having grandiose delusions, and that includes them having special powers. People may have persecutory delusions, feeling that people want to specifically harm them. An example might be that MI5 is following them. People may have delusions of control or delusions of reference, so that the TV, newspaper, radio contains messages which are specifically intended for them. People can experience hallucinations of different kinds, auditory, visual, smell, taste, but the most common are probably auditory. It's really helpful to try and capture exactly what people are experiencing. So if they can tell you what voices are saying, that's really useful information to include in a referral. There are different ways of classifying hallucinations, be it second person, third person, but if you can capture the content, that's probably the most helpful. Thought disorder, is definitely a symptom of psychosis, and the way to recognise that is that the words make sense, but the sentences don't. And typically the person is unaware of this problem. So I briefly mentioned the at-risk mental state before, and this is the period that immediately precedes the period of psychosis. And these people can be referred in exactly the same way. There are three kinds of at-risk mental state. These include attenuated symptoms, so milder psychotic symptoms. That's the most common. The second most common is people with brief, limited, intermittent psychotic symptoms, also known as blips. And these tend to be both short and self-limiting symptoms. The third and least common, but most easily recognised, is people with a genetic risk and a functional decline. So the genetic risk needs to be in a first-degree relative, a sibling, a parent, and the decline in functioning needs to be large. So typically someone that's working or in education and then is barely able to leave the house. So to illustrate this with another case history, and this is of a 22-year-old man who hears voices which mock him, calling him a fake. He feels that his head is being actively pulled by spirits, and he relates this to a neighbour who is tormenting him. So the two questions to consider are, what symptoms are being described, and also what risks would you consider in this case? So if you want to pause the video and spend some time thinking about those. So I think the symptoms are of auditory hallucinations, also of passivity phenomena, that his head is being pulled by something outside of him, so it's not under his voluntary control, and also persecutory beliefs. He feels that something bad is being done to him. In terms of the risks, there are two risks that you should consider. Perhaps the more obvious one is that to his neighbour. So he feels that this neighbour is behind all of these things that are happening. So you have to consider what risks, what threats, what contact he has with that neighbour. And the second risk is to himself. Logically, it might be that these experiences are so distressing, so tormenting, that he sees suicide as his only viable option to resolve them. So to move on next to specific advice for GPs. We've covered the psychotic symptoms, which are of course important, but the history you may get will only cover a decline in functioning or a change in behaviour. And that may come just from the family, so it's important to listen to family concerns and really tune into those. You need to consider a family history of psychiatric illness, and particularly if there's a family history of psychosis, that may well be telling. You need to tune into the presence of drug use and to understand the nature, pattern and frequency of drug use. Importantly, don't forget their physical health and to ask yourself, is that what's causing this problem? I don't think that should delay referral, but it might be something you investigate in parallel at the same time as making a referral to mental health services. So some useful screening questions. Have you had experiences lately which you can't explain? Do you feel that things around you have a special meaning? Do you worry that people are looking or talking about you? Do you worry that people are following you or monitoring you in any way? Do you feel that your thoughts or actions are being controlled? And do you hear voices or see things which other people can't? And again, if you want to pause the video now and just ask yourself what symptoms are being asked about. So, to go through those in order, these are a delusional mood, delusions of reference, persecutory beliefs, passivity phenomena, and auditory hallucinations. So what should GPs do with someone with first episode psychosis? Well, given that you've now recognised someone because of the symptoms you've noticed, I think it's important to talk in terms of symptoms rather than getting into discussions about the condition or the diagnosis. I think at this point, when people are terrified, trying to make sense of their experience, it's rarely helpful to get into a discussion about diagnosis. I think it's crucial to offer hope. With the right care, this is a really treatable condition. I think at the same time as making a referral, you should offer follow-up as a safety net in case what we expect to happen doesn't. And as I said before, it's really important to tune in and address family concerns. In terms of medication, NICE is very clear that GPs should not be initiating antipsychotics in primary care unless you're doing that in consultation with a psychiatrist or a mental health team. It would be entirely reasonable to consider a short-term prescription of benzodiazepines such as diazepam, and typically a dose of 5 milligrams twice a day. And as we've said a couple of times, do consider and keep their physical health in mind. So what should you do if you're uncertain about someone's diagnosis? Well, EOP services are not diagnostically led and are very comfortable with diagnostic uncertainty. So if you suspect that someone is having a first episode of psychosis, then my advice is that you refer for assessment. Just in passing, some early intervention services only work with people 14 to 35, but as this target applies to people 14 to 65, you should refer in exactly the same way. Again, it's not just about symptoms, so you should consider a family history of psychosis. you should look for a decline in functioning. And bear in mind that auditory hallucinations in their own can be a poor discriminator of psychosis. They can occur normally or in other conditions, but it should prompt you to take a fuller history looking for some of the other symptoms which we've discussed. So again, to illustrate some of these points with a case history, we meet a 20-year-old university student in your surgery. The history you get is that he's stopped going to lectures, he's seen his friends less and spending more time in his room, and the family have brought him back from university, back to the family home, and he tells you that he's got a growing belief that people are talking about him and a belief that he's being followed by people he's unsure about. The early intervention team met him at his home, and they spent time both alone with him and with his family. He was seen the same week as he was referred, and our initial action was to take a fuller history of the problem. And we established that he had a history of psychosis, and also that he had a concurrent drug problem and that he was smoking a lot of skunk while at university. It also revealed that there was a family history of psychosis in a maternal aunt, and she'd had a period of treatment some years ago, but has since lived a very normal life. Himself, he was very hesitant about medication, but he began individual psychology the same week that he was seen. With his permission, there was some contact with the university so that they understood in broad terms his reason for absence. There was a lot of contact with the family so that they understood what was happening, and also that they could focus on their own health, preserving their ability to support him. There were some discussions about his drug use, so that he was able to develop a link between his drug use and the onset of his mental health problems. So in terms of recovery, it's important to remember that the majority of people will make a complete recovery, and it's only 10 or 20% of people that will develop persisting symptoms. 25% of people will never experience a subsequent psychotic episode, and it's one of the principles of early intervention that a slow or partial recovery is managed assertively. We know that each relapse that someone has represents a potential point for people to develop a more enduring impairment. And again, be positive about people's recovery. So to summarise some of the main learning points from this video, psychosis is very treatable, but early treatment is vital. What I want GPs to be able to do and be confident to do is refer if you suspect psychosis. Talk about the symptoms, don't get caught up in discussions about diagnosis. Be hopeful and listen and act on family concerns. So just to cover some references, and of these I think the best is the IRIS initiative, and that contains a whole host of resources specifically for GPs. And also the My Health London, which again contains a number of really useful resources. So thank you very much for watching this video, and I hope that you find it helpful for your own learning and crucially for the patients that you see.